Good morning, everyone, and welcome to another Changing the Way We Work community of practice for Ontario family physicians. And thank you all again for joining us. My name's Ali Damji, and I will be one of the moderators for today's session. But I would actually like to call my co-moderator, Dr. Eleanor College, up, if she can turn her camera on, because we have a bit of a special announcement for today because it's a big occasion. So, Eleanor, if you can come on.
Great, thanks, Ali. Very happy to join. Maybe next slide, please. So before we got started, or before we get started on the topic for today, we just want to take a moment to reflect on the fact that this is our 100th session, which we're thrilled about. And we wanted to take a moment to recognize some of the people who've played a huge role in both getting this started and making what it is today. So I'm going to introduce them in turn and ask them to turn their cameras on so everybody can see their faces and perhaps remember seeing them a few years ago as well. I'd like to start with our OCFP president. So first of all, Dr. Jennifer Young. She was the OCF president from 2018 until 2020, and her leadership continues to inspire and guide much of our success. Thank you for joining us, Jennifer. Next up, Dr. Elizabeth Mugga, who served as the OCFP president from 2020 to 2022. She's currently the Senior Clinical Advisor of Primary Care for Ontario Health and plays a central role in the province's primary care action team. Liz was integral in bringing the community practice to life and co-hosted until the fall of 2022. Thank you for joining us, Liz. Next up, Dr. Mehle Kumanen. She's the Chief of Family and Community Medicine at the Two Rivers Family Health Team and was OCFP president from 2022 to 2024, also co-hosting the community practice during her term. She's been a tireless advocate for family physicians and championing innovation across the province. Now I'd like to turn things over to two of our DFCM faculty who were pivotal in supporting the establishment of this community of practice. First up, Dr. David Kaplan. He's the Vice President of Quality at Ontario Health and an Associate Professor at the University of Toronto. He served as the co-host of the community of practice into the fall of 2022 and helped shape countless sessions to meet the urgent needs of family physicians across Ontario. And then last but definitely not least, Dr. Tara Kieran. She's the Fidani Chair in Improvement and Innovation and the Vice Chair of Quality and Innovation at U of T, Department of Family and Community Medicine. She's played a vital role in the success of changing the way we work, moderating a whopping 64 sessions, starting in 2020 when she helped guide us through the pandemic, to today where she continues to challenge us to think about how we can work differently and better in our provision of excellent primary care. And I'm going to turn things over to her for some comments. Thank you, everyone, for joining us.
Yeah, I just wanted to reflect on how far we've come. We started this as a place for people to gather because we knew we needed to come together to think about how we want to work differently in the pandemic. And in the beginning, it was just, 100, 200 people gathering, and it grew and grew because of the need for us to come together. And we had the opportunity to bring on not just experts from outside of family medicine, but so many of our colleagues who are doing incredible work. And so I just reflecting on that time, wanted to thank all of you who have attended over the years and made this the special, safe, warm, interesting place that it is, this community of practice that is inviting and continues to thrive. And wanted to also, I know we'll do some more thank yous, but just to say what an incredible team we have at the OCFP and the DFCM that allow us to continue to have this. There's so much work behind the scenes, and thank you to the incredible team that makes this happen every 2 to 3 weeks.
Thanks so much, Tara, for your words and reflections. And we are very grateful for the leadership and the guidance and the commitment that's been critical to this community and to the care of patients everywhere. So just with that wonderful, warm start, I'm going to turn things back over to, I think, Jobin.
Thanks so much. And just a thank you from the OCFP on behalf of myself as president. I know our CEO, Dr. DP Sewer, is online as well. Thank you from our entire board and to our team and the DFCM team. Thank you so much. And just as we continue on from the celebratory start, we'll go to the next slide. And I want to start us off with the land acknowledgement. We acknowledge that the lands on which we are hosting this meeting include the traditional territories of many nations. The OCFP and DFCM recognizes that the many injustices experienced by the Indigenous peoples of what we now call Canada continue to affect their health and well-being. The OCFP and DFCM respects that Indigenous people have rich cultural and traditional practices that have been known to improve health outcomes. I invite all of us to reflect on the territories you are calling in from as we commit ourselves to gaining knowledge, forging a new culturally safe relationship, and contributing to reconciliation. Just a quick thank you again from all of us. And with that, I'll pass it back to you, Ali.
Great, thank you so much. So if we can go to the next slide, please. So just as a reminder for everyone, these are accredited sessions, and they are ones that are able to be submitted through the main pro process as well. And just want to give a quick shout out to the planning committee as well. And again, thank you all for all of your commitment and engagement and helping make these sessions what they are. There's a lot of work that goes into them behind the scenes, and really appreciate all of you. So thank you so much. Next slide. Just as a reminder, if you do miss the session live and you want to earn credits, you still can through the self-learning program. There's a form that you have to fill out in order to do so after you watch the session, and we've included the link in the chat there. Next slide. So this will be our panelists today. We're very excited to have both Dr. Warshafsky and Dr. Moore joining us today, and they will be speaking to you very shortly. Next slide. So we'll start with the speaker disclosures for both of them. So starting with you, Daniel, and if you want to just introduce yourself as well.
Yeah, of course. Hi, everybody. Daniel Warshafsky, one of the Associate Chief Medical Officers of Health for the province. I have nothing to declare, but 100 episodes. This is great. We can go into syndication now. It's very exciting.
Awesome. Over to you, Dr. Moore.
Kieran, thank you so much for the invitation. I'm the Chief Medical Officer of Health. I'm salaried employee of the ministry, and I have no disclosures and no conflicts to declare, but thanks again for the invitation.
Thank you so much. Thanks for being here. Next slide. Over to you, Jobin.
So much. Hi, everybody. I'm Jobin Varughese, President of the Ontario College of Family Physicians, and I hold a position at the Toronto Metropolitan University School of Medicine, where I hold as Assistant Dean Primary Care Education.
Okay, and then for myself, so I wear a few different hats, the main one being an academic family physician at the Credit Valley Family Health Team. But in addition to that, I do receive some honoraria from the Ontario College of Family Physicians for this role, from the OMA, from Trillium Health Partners and the Canadian Mental Health Association for different leadership roles. I work with the Center for Effective Practice and have received, on occasion, last time a year ago, one-time honoraria from GSK. And then I do sit on some advisory boards as well. None of these pose a conflict for today's session. Over to you, Eleanor.
Thanks. And I'm an academic family physician at Southeast Toronto. I'm the CPD program director, so do receive a salary for that from the Department of Family and Community Medicine, and speaker honoraria from the OCFP, and also some honoraria for some work I do for the Foundation for Medical Practice Education. None of it should be a conflict.
Awesome. Next slide. So as a reminder to our participants, and for those of you who are new, all questions should be asked using the Q&A function at the bottom of your screen. So if you have a question, please submit it there, not the chat. The chat should be used more for networking and for talking about maybe your reflections on what you're hearing. But if you do have a question, please put it into the Q&A, because as the moderator, that's where I'm looking for the questions to ask our panelists. And if you have a question, before you submit it, please take a look through what's already been submitted. And if someone's already asked the same thing, please upvote it, because the most upvoted questions will be the ones that I will ask. Next slide. And so with that, it's so great to see so many of our colleagues here today to celebrate 100 sessions of changing the way we work. And so now I'd like to take a moment to reflect on the past 99 sessions and how what began as a small but urgent response to a global crisis has now grown into an enduring testament of collaboration, resilience, and innovation. And thank you all so much for the kind comments that you've written in the chat. I've been seeing them come in, and it's really nice to see that it's appreciated by the community. So, a few years ago, when the pandemic struck, many family physicians found themselves navigating uncharted territory. We were facing rapidly evolving public health guidance, shifting clinical protocols, and the pressure of delivering care in a really uncertain environment. It was in that moment of crisis that Changing the Way We Work was born, originally launched as the COVID-19 community of practice. Next slide, please. And so over this time, this has evolved into a space for learning, exchange, and support. Every few weeks, family physicians across Ontario have had the opportunity to connect and hear from experts in policy, clinical practice, and practice management. And importantly, we've also learned from each other. Topics have ranged from virtual care, community collaborations, mental health support, public health, chronic disease management, and even emerging care models to show us the future of what care could look like. Next slide, please. And so now we thought we'd try something fun. We'd like to hear from you, and we want to know what is one way that this community of practice has impacted your clinical practice. So if you guys can help us out, if you can scan that QR code or use the link that we just posted into the chat, click on it and enter a word or two about what this community of practice has done for you in terms of impacting your own practice. And hopefully we'll see some things populate. Thank you so much. This is amazing. And I also will highlight some of the things coming out in the chat as well too while that's populating. So thank you so much for the comments here, wishing us a happy birthday and also saying that it's been a trusted source of information about COVID vaccination, which was so helpful, especially during those early days as well when we were really needing to build the public's trust. Talking about how it's always up to date, how people really keep it in their calendars to make sure that they don't miss it. And wow, you can just really see the common theme here. I think the date's probably referring more to up to date, I can see. And then also connection, learning, support, education. All of these are very common themes as well. So thank you so much for this. This is amazing to see. All right, and then with that, I'm going to actually turn things now over to our speakers. But thank you all so much because this community would not exist without each and every one of you. And that's why we wanted you to populate that word cloud because you're what makes this community what it is. And so with that, I'm going to turn things over to our speakers, Dr. Warshafsky and Dr. Moore.
Morning. Next slide. Yeah, so from our office, from Daniel and myself, thank you so much for the invitation. Thanks for starting this initiative. I love the comments on connection and learning and support. This is a key instrument for us in the public health division, in the public health world, to keep connected to our key colleagues in primary care. And we've honored the opportunity to participate, to keep you informed of the various. Yes, we started with COVID. Now we're dealing with influenza, RSV, COVID, measles, other infectious diseases. And this is a key avenue for us to work with you. And I also have to celebrate my colleague, Daniel. I've attended many of these. He's such a great presenter. He keeps you informed. He's on the pulse of all of this information. I'm honored to work with him as a great colleague. And I've listened to his Q&As. He's fabulous in keeping you informed. And I can't thank him enough for his ongoing participation over your last 100 sessions. Next slide. So I wanted to give you just context of this, our preparedness cycle and our yearly planning now, because we're trying to learn from the pandemic and ensure that we use every annual epidemic of viral disease now as a means of preparing and staying prepared. Next slide, please. So we now have an annual cycle of preparedness. It's continual, where we go through various stages in that IMS emergency cycle of mitigation, prevention, preparedness, response, and recover. And now we're certainly in the response phase as we're seeing a rise in influenza in particular, and RSV will follow. Hopefully COVID will behave itself. But this preparedness cycle, we're dedicated to continuing on an annual basis and keeping you informed through this avenue, but also through multiple means to keep you informed of the risks, and we're monitoring them in real time. It's a commitment we made to you. So my first report as the Chief Medical Officer of Health was called Being Ready. And we made a commitment to learn from the pandemic, to have improved knowledge translation and partnerships like this with primary care, to ensure that we keep you informed of any ongoing risk. With this cycle of preparedness, we work with all of our partners, long-term care, acute care, primary care, pediatrics, retirement homes, to have an annual cycle. But right now we're in the midst of our influenza activity, and Daniel will go through that with you. Next slide. We also, in that document called Being Ready, made a commitment to you to maintain all of the components that we developed during the pandemic for the annual epidemic of respiratory illness, because we think if we're good at annual epidemics, we can be great at pandemic preparedness and response. So you'll see here where we have ongoing 365 surveillance of the respiratory season globally. We're watch the Southern Hemisphere during their winter. And see how that can apply to us. We have made robust improvements in our immunization, as you've been made aware through this interface, on improving RSV protection for newborns and for our elderly. We've expanded our other vaccines, including pneumococcal. We've maintained a population-based COVID vaccination as compared to other provinces. We maintain our universal influenza program. We are constantly looking at new and better testing that you could use in your office. We're maintaining capacity for therapeutics. We're never going to run out of Tylenol in the shelves of our pharmacies. Again, I have an ongoing relationship now with pharmacy industry to keep them appraised of our acute care activity and infectious disease activity. Much better relationships with long-term care. We have a table with all of our pediatric hospitals that we speak to on a regular basis to keep them informed. We are improving on our infection prevention and control and how those services can be offered to you in your offices through Supply Ontario and free ordering through Supply Ontario. We've improved our work with public health in terms of outbreak management. And now we have, I think, much stronger relationships with our primary care partners. So I hope you're seeing that we're committed on an annual basis to maintaining this response plan. Next slide. And we go through planning scenarios with our acute care partners, with regional Ontario Health, with long-term care. We put them through exercises in the summer where we go through baseline scenarios and then surge scenarios for increasing admission patterns to hospital, and ensure that they have a plan to be able to respond. And just with Halton Hospital just shared with us a very robust plan and based on bed occupancy, where they increase their response plan as admissions increase. Next slide. We also are maintaining all of our communication pathways and our leadership team pathways. So we have an incident management. If you don't know, we're meeting every 2 weeks with all of our health system partners, Ontario Health, long-term care, emergency preparedness, Public Health Ontario, Supply Ontario. We accelerate those meetings. We basically start in October, accelerate them as the respiratory season accelerates, and now we're meeting weekly going forward to ensure everyone has the supplies. We know where we're at from a surveillance vantage point. We can have predictive and forecasting tools to be able to enable them to understand where we're at, and we keep you informed of where you're at in the epidemic curve of all of the various illnesses now. And we liaise back to all of our health system partners and public health agencies at a local level should be doing that as well, keeping their health system and partners informed. So we're maintaining our state of preparedness, our state of response to ensure that you're informed and that we provide the best care to all Ontarians. This format will just be expanded if we have a new pathogen or a new pandemic, and will maintain the same interface, the same connectedness to ensure that we know who is responsible for what actions throughout the health system. So I think given annual preparedness, it will put us in a very good place for our pandemic preparedness. And even this year, we offered a pre-pandemic vaccine. So you've heard of highly pathogenic avian influenza, killing many birds. Some humans have come down with it. We've pre-vaccinated those that are at the highest risk, those that are dealing and working with these animals, and are monitoring the effectiveness of those vaccines serologically, as well as we have a supply chain to be able to enhance that vaccine supply if necessary. Next slide. and it's a cycle of preparedness, as I've discussed. So it's all year round, ensuring that we educate, that we keep people informed, we model the activity levels, work with all of our health system partners, and you in primary care are one of our key partners, and this avenue has been fantastic to help us understand what your questions are. It helps us with our further communication with the field beyond you early and keen adopters who are here on a Friday morning. And it's continuous as we monitor globally what's going on. We get a weekly risk assessment of all viral pathogens that we assess and ensure that we have a preparedness plan for. Next slide. So I'm going to hand it over to Daniel. I can't thank him enough. He's going to go through where we're at in Ontario right now in terms of staying prepared. We are in a continuous quality improvement cycle in our plan. So if you have suggestions for us, we'll review them, we'll adopt them, we'll work for the Centre for Effective Practice and others to ensure that you have tools in your practice. This year we've adopted, and Daniel will describe, stabilizing the highest burden of illness patients. So those with asthma, COPD, CHF, who, if they come down with a respiratory illness, have a higher risk of admission, how we can stabilize them medically and have a rescue plan for them. But if you have any other additional recommendations for us in terms of changing the way we work, improving our outcomes at a population level, we are all ears and can't do any of this work without you. And thank you again. I'll hand it over to Daniel, who will go over the seasonal epidemiology.
Great. Thanks so much, Dr. Moore. And we can go to the next slide, but just a huge thanks to all the OCFP, obviously, for letting us come here to share with all of you. And biggest thanks to everybody who just comes, as Dr. Moore said, on Friday mornings just to listen to us talk. So you guys are doing all the most amazing work, and we can't share our appreciation enough. So we want to talk about what we're actually seeing today, and given where we're at, beginning here with what are our trends over the last 5 years for everything we're talking about. So since even before this call started. So we obviously, COVID had been in the last 5 years the big piece, but I think what you can see from the COVID trends here on the top left, this is our percent positivity in testing for people with respiratory presentations. Is it still pretty variable, but it seems to be falling into a little bit more of a pattern, right? You can see how very in the early stages of COVID, it was all over with new variant. There's the big Omicron spike that we all really, didn't enjoy seeing. But then it's kind of settled a little more into a pattern, which is earlier than flu. And I'll show these kind of overlapped in a bit to see the comparison. And thankfully this year, COVID is doing quite well, as Dr. Moore said. Alternatively, you can see flu in the top right. We didn't see flu for a couple of years when COVID was here, both from all the protective factors we were doing against COVID with our masking and hand hygiene and physical separation. It really cut down flu to almost nothing. And then, last year it really came rip-roaring back with one of the worst seasons we've had in a very long time. And RSV, you can see here, again, like this one didn't entirely go away over the COVID time, given that kids, again, were obviously still circulating quite a bit, and that's where most of the spread happens. It's been pretty stable, but we're probably getting into more standard trends for RSV in the next coming up years. And obviously, the biggest thing, we have all the protection against RSV now. So next slide, please. This is just those overlapping curves. And again, I think we all remember the triple-demic year a couple of years ago where we had 1, 2, 3 peaks all on top of each other. So you can see that doesn't happen always. We do have differences in when these are coming and going. This year is a big difference, again, as Dr. Moore said, with flu coming quite a bit early. But all of our preparedness cycle, those goals that Dr. Moore mentioned, are in case we have that significant overlap of our biggest 3 respiratory illnesses on top of each other. That's not even including if we have a really bad, mycoplasma year like we did last year, for example, where we want to be prepared for the system. But these are settling into more patterns where they are a little bit off from each other in the standard year, and we can hope for that to be what we see. So next slide, please. And so this is where we're at right now. So this is kind of the template of everything that we use normally when we're looking at their patterns, when we're going through that preparedness cycle, when we're having our weekly meetings, looking at COVID, flu, and RSV. Not to go into detail here, but you can see right now, obviously, flu is the big one, almost 20% positivity. So really increasing very quickly in terms of our flu positivity. We're well into the season now. It's only been 3 weeks since we hit that 5% positivity. And when we hit that, it just shoots up and we're in it. COVID is remaining fairly stable at low to moderate positivity levels, but it's still I think the thing with COVID we want to show is even when positivity is relatively low, it's still a significant burden in our hospital system. So that 5.5% positivity, we're still seeing 170 new patients a day in the hospital with COVID, which is quite a lot. Flu is now overtaking it, but that's at 20% positivity. So the burden from COVID, particularly for individuals who are older and higher risk, is quite significant. RSV, very slow going right now, and I'll show a little more on the next slide. So if we can go to the next one, please. So this is where we're at right now with some a little bit of projections that we have for this season. You can see for flu compared to the last few years, we are like well ahead, 5 to 6 weeks ahead of the last few years, and elevating very, very quickly. COVID, thankfully, remaining very stable, but we are expecting a bit of a bump as we get into December. That is what we've seen almost every season for the last few seasons, is that the holiday transmission of COVID does increase. What we're hoping is it stays relatively low, in keeping with the low COVID rates we're having right now. I think one of the most interesting is the RSV positivity on the bottom left, which is still quite low, and you can see going much more slowly than it has over the last few years. This is a little bit more in keeping actually with what RSV looked like prior to the pandemic. Post-pandemic, it has been more of an accelerated season, but this low and slow is something that hopefully sticks through for the season. And again, we have lots of protective factors now to hopefully keep the hospitalizations low as a result. So next slide, please. For RSV, this is what we're showing the difference in terms of that older adult versus the infant peak. So obviously that double peak where kids first are getting it, we see hospitalization in the pediatric population, particularly kids under 2. And then, a few weeks later is when we see it for older adults, maybe 2 to 4 weeks later. So you can see the last few years plotted on here, particularly the positivity last year. You can see that is more into January, into mid to January for older adults, where usually we're seeing it in December for that pediatric population. Next slide, please. This one is our hospital emergency department system. So the ACES system this is live time information that's pulled from all emergency departments across the province. And the dark black line is where we're at right now. You can see the most of this season has actually been trending quite low, but we just hit that big uptick. You can see it most predominantly, I think, in that 0 to 4 and then 5 to 17 ages where we're really seeing the big swing, but it is creeping up in the older adults as above. Again, we see that little bit of a break where first it's usually the younger population that gets it first, and then they're passing it through to parents and grandparents, and we see that peak in the older adults later. But for all of you who are probably seeing the huge number of sick kids coming into your offices right now, that's what we're seeing across the board, across the province. Next slide, please. So this is our hospitalization, and this is where for flu, I want to talk a little bit about what we're seeing for flu in terms of the strains. As we mentioned on the call before, this year is looking to be a very significant H3N2 year for flu. So H1N1 and H3N2, we usually see variability every year. The last several seasons have been more H1N1 dominated. It tends to be a little bit lighter in terms of hospitalization when we see an H1N1 year. The other thing for H3N2 is this year, the strain was basically newly developed at the very, very tail end of the Southern Hemisphere season. So they had a bit of an extended season with this new strain, and that's what's been driving most of the flu that we're seeing in Ontario and in the Northern Hemisphere broadly. So Japan, UK having very, very early significant flu seasons, ours being, 5 to 6 weeks early than what our average might be normally, and really driving hospitalization. The concern that we have with that one, and we'll get more into it with the antiviral discussion later, is because it's a new strain, it's not exactly matched to what was picked before in the season. We don't have as good idea how effective the vaccine will be against the current strain of H3N2 that's circulating. For H1N1 or flu B, we know it's really doing quite well. That effectiveness looks very good, and we have a good match. But for the H3N2, it's just yet to be seen. We're hoping it still proves effective and still strongly recommending everybody get it if they can, because it will still make a difference. But this is where we want to just be extra careful around that one. And at this point in Ontario, it's almost 90 to 95% of our flu A is this newer strain of H3N2. Next slide, please. This is showing the RSV peaks, the difference here. You can see right now, again, we're very low for hospitalization across the board. And I think a big part of this is the amazing work we've done through all of your offices, through hospitals, to get those RSV immunizations into both our infants and older adult population. So last year, you can see, was hugely impactful hospitalization of RSV in older adults. This year, we have the RSV program going out We know there were a little bit of hiccups with supply in the early part, but hopefully that's been smooth for most people for the RSV vaccine now. But that'll protect for older adults. And we know that for those infants, we're still seeing steady uptake in the hospital sector. So despite what we showed in terms of positivity increasing, hopefully hospitalizations are going to stay much lower than positivity is indicating for us. Next slide. And this is where we're at for our immunizations. So for COVID, it's for all comers, all channels. For flu, it's only the pharmacy data that we're able to get in a timely fashion with this one. You can see our COVID uptake is low, much lower so than it was in pandemic times. But I think the concern is really that those older adults, and again, we show that that's still a significant number of hospitalizations a day, the uptake keeps dropping every year. So in just the 65%, the 65 years and older population, we're just under 30% coverage. Even for long-term care and retirement home residents, which are some of our most vulnerable, we're only at or under 40%. So it is something that we're working on. Flu is pretty steady in terms of uptake. We did have, some really great years in the pandemic when we were really trying to protect against multiple. It's stabilized now to kind of the standard uptake that we normally see for flu. So what we're seeing in the pharmacy sector is, almost 1.6 million doses. And that's in addition to everything that you've all been doing in your offices. So we know the numbers are looking quite good for flu, and that we think the coverage is probably doing very, very good for flu at this point, at least in keeping with our normal seasons, which are in older adults, we aim for 65 to 70%. I mean, our goal is 100, but 65 to 70% is kind of what we expect and see. And so I think we're probably hitting that mark. So next slide, please. I want to talk quickly a little bit about some really new resources that came out from Ontario Health this year. So if we go to the next slide. So Ontario Health this year, and hopefully going forward, has put out seasonal influenza treatment guidance. And so this is based on the standard guidance that's come out from AME for many years, and is really the best practice and best evidence we have right now for what we're seeing. So if we go to I'll run through these really quickly because you all take a look. But for the next slide, just an example, they have a lot of very simple to use algorithms for severe, non-severe adults, pediatric. And I think the real message we have today is because of what we saw for that little bit of a mismatch with the vaccine for flu this year is probably want to have a bit of a lower threshold for giving oseltamivir or Tamiflu this year than we may have previously. So again, even though normally it's still recommended empirically for those highest risk populations. Obviously, testing is not something we have readily available for flu without having rapid tests, then given the 48-hour timeline to get treatment in. But if you have really, really high risk patients, it's something to consider, again, especially this year when we know the vaccine may not be as effective as in previous seasons. So can run through the next slides. It's just a couple examples of for pediatric population, what you'd be looking at, again, within 48 hours. But even for beyond 48 hours, if you have really high risk groups, it's still something that you might be considering to provide. So next slide, please. And then that last one here is, as Dr. Moore mentioned earlier, about the whole preparedness cycle starting in the summer with individuals who may have chronic respiratory conditions. If we go to the next slide, we've shared before a couple pieces. So CEP, the final pieces of this seasonal preparedness resource are just went out, I want to say 3 days ago. I'm sure the link is in the chat already as I'm speaking. But this is a really wonderful tool. And if we go to the next slide, again, it's starting with in the summer, how do we optimize for those chronic conditions, whether it's COPD, heart failure, asthma, whatever it may be. We know that those individuals are highest risk for both, for complications from respiratory illness, but exacerbation of those underlying conditions as well when we get to respiratory season. So we want to get that really, really early. As we get into the fall, it's proactive. It's making those plans about how to access your testing, your treatment, setting up your office practice. And again, they have wonderful tools about practical office management in the season, getting immunizations in, monitoring. And then once we're in the winter now, it's identifying and treating as best we can. So it's, this is that prevention and response right through the entirety of the season to make sure that we're all prepared as best as we can be. Next slide. And again, this is the one that just came out. This is the testing and management piece. So it pulls together pieces from what we already have out about testing, who's eligible with recommendations from that Ontario Health antiviral guidance that I mentioned already for flu specifically, plus including the COVID antiviral guidance, which is, hasn't changed since last year significantly, but is also updated by Ontario Health. So it's kind of all in one nice, pretty simple, easy to use package from Center for Effective Practice here. I know OCFP has a whole bunch of complementary one pages to go along with this as well. So next slide. I think that one was it from me, Ali.
Yeah, I believe so as well. Yeah, so we can take those down. Thank you both so much for such a great comprehensive presentation there. And we have quite a few questions here, so we can jump right in. So the first question that has the most upvotes here is, can someone please comment on the evidence for Paxlovid? It seems to be hard to access.
Yeah, happy to. Oh, sorry, the buttons changed for a second. Yeah, so what we have seen is that with increasing immunizations, with the change in the strains for COVID, that Paxlovid, the populations who should really get it have been narrowing. So if you look at the latest Ontario Health guidance, so they did a thorough review pretty recently, I don't remember exactly when, maybe 6 months ago, for both severe hospitalized and outpatients. And certainly it's those highest risk groups of older adults, particularly those with chronic medical conditions, who really you should be thinking of for Paxlovid. Outside of that, if it's a younger person who maybe has a chronic condition, it's a little bit more for consideration. And that some of it is just your feeling understanding of that patient's frailty, and their likelihood to have more severe disease. But the Ontario Health Guidance does go into detail of it. It is still useful for those highest risk groups, even if they've been immunized this season. It does still reduce hospitalizations in that population. But as we get to younger populations or those without comorbidities where hospitalization from COVID is already very rare, that marginal benefit is pretty minimal, and so it's not recommended for those groups anymore. But older adults, particularly those who are more immunocompromised, have underlying respiratory disease, absolutely still recommended.
Great, thank you so much. This next question's great. It's what can be done to improve communication with the public in an era of disinformation and widespread suspicion of expertise?
So I think we have a long ways to go. What we're trying to do from a public health vantage point is to understand knowledge, attitude, beliefs, behaviors for vaccines. Our current numbers are decent, and we're seeing decent uptake and no significant decline except in COVID vaccination, which may be a normal waxing and waning in regards to COVID. But we want to be able to have population-wide surveys, follow that knowledge, attitude, beliefs, and behaviors. And once we understand changes longitudinally in that, we need to have a comprehensive social media and media-based communication strategy. We have to be able to give you tools to help on the clinical one-on-one interface, but also being able to promote vaccines at a population level. We're absolutely working at that at a national level, and trying to get the survey data integrated into a community health survey longitudinally. But we have to have it in Ontario, and then we'll build the tools at a population and clinical interface to help. Daniel, any other comments?
No, I think you covered. The only thing I'll say is that still the number one thing we see that changes kind of hearts and minds is that trusted healthcare provider, right? It's everyone on this call that makes the biggest difference. It can take a lot of time. We do absolutely know that, and I think we just all appreciate when people are taking the time to do that. But that makes the biggest difference, and we're hoping that we have more resources like that to help all of you with sick kids in Scarborough with their vaccine consult lines, for example, and can we get more of that available to help everyone across the province?
And also, thank you during measles, we maintained high levels of immunization and protection for one of the most infectious agents. Yes, we had 2,300 individuals get measles in Ontario, but they were unvaccinated individuals that are historically unvaccinated. So you at the clinical interface have been able to maintain high levels of immunization. We don't have good information systems yet, but we are all, Daniel and I, working internally to ensure that we have a vision of having one immunization record for all Ontarians so that you can understand, given our immunization system at present, if your patient's covered and protected and can have that clinical discussion on the benefits of vaccines. So we're pushing for the information system that'll help you as well.
Thank you for that, and thanks for sharing that too around the measles aspect there, because I think it's hard sometimes for us to appreciate the population level impact that those individual actions are having in primary care. So really appreciate you sharing that because that's really nice to know. The next question here relates to masking in particular. So this is going back to 2022 when there was the transition from a mandatory order with respect to masking in the hospitals to the standard of care. And so now it's a normal state of affairs that all of these sites and partners will continue with the best practices in keeping with the standard of care. So the question here is, can one of you comment on how we can encourage continued masking in healthcare? Because it seems like it may not always be the standard of care anymore, and sometimes even patients may get pushback from healthcare providers when they request them to mask.
Yeah, I can start. So certainly in like the hospital setting, it's every hospital setting their own policy, but this is the recommendation that comes out broadly from, the Ontario Hospital Association, from Ontario Health, recommending that yes, now's the time. And again, that's part of what we're doing when we're talking with Ontario Health regularly is, okay, you should all put your masking policies in place now. And I think, at least the hospital I work at, it's been in place for a couple of weeks now. So that is still the most effective in the hospital policy. I guess, obviously part of it is in all of your own offices. How do you implement something like that? How do you encourage patients? I think it's still important for us to be doing that public messaging, as Dr. Moore mentioned, about now's the time in the season. It is still really effective, and people really should be masking, particularly in these sorts of settings if they can. But some of it's going to be implementing that policy in your own office and making sure that you and your staff are doing it in the same way. So there's lots of things to consider for individual patients who are maybe refusing. It can be really difficult. Sometimes in the hospital setting, it's maybe easier to say, well, sorry, but we want to treat our patients still, obviously. We want them to come in. If it's someone who's refusing, you try to get them into a room right away from the rest of the crowd. Like we see what else we can do to try to move around something like that without causing too much of an issue. But I don't know, Kieran, if you have other thoughts.
No, so I look at Public Health Ontario respiratory virus tool. It can be broken down regionally across Ontario to 29 health unit levels of geography. So you can see the level of activity. Influenza won't rise at the same pace across Ontario. It is differential. And you could either watch your local public health agency's website and or Public Health Ontario's respiratory virus tool to understand the epidemiology. But as soon as you see we're greater than 5% influenza, the risk of spread in closed environments increases dramatically, and you don't want spread within your waiting room or within your practice. So I'd base it on the best evidence, and I think that would be an evidence-informed means of protecting yourself, your staff, and your patients. The other component is, please remember, Supply Ontario it has an online ordering tool for all of your IPAC needs. We want to ensure that is used, so the government continues to fund it, so that you have the tools to be able to protect yourself and your patients as well.
Okay, that's helpful and clear from both of you in terms of, I guess, when we should implement those procedures. When does the standard of care come into effect? And then it sounds as though like really the standard of care in this time is to mask. And so hopefully, if patients are experiencing pushback from the healthcare providers, hopefully they can understand that as well too. That this is important to be doing right now in the state. And then in terms of the next question here, this is more of a logistical one around, can you please explain the percent positivity rate figure that's on the Ontario respiratory virus tool? Who is actually getting swabbed to create this number? Is it only hospital patients and those in nursing homes, given that we don't typically have access to these swabs in the community?
Yeah, so it is everybody who's getting these tests across the province. So we do have the Sentinel Physician Surveillance Network. So there are, primary care providers who are doing testing that contributes to it. The majority is still hospital, long-term care homes, retirement homes, those settings where patients are more likely to be getting those tests regularly. But across the board, that gives us still a really good example of positivity. What it obviously does miss is a little bit in some of the pediatric population who may not go to hospital with it. So it's still a really good representation of where we are in the cycle right now. And again, any kid who's going to hospital, they're still getting swabbed, but you may be seeing a lot more in your offices than go to hospital. And so for pediatric in the early part of the season, it's probably a little bit higher. What we can see right now, so for flu, for example, I think last week, our global percent positivity was 10%. When we pulled out just that pediatric part from hospital, it was nearly 30% already last week. Just the differences there. So that one global number can swamp a bit the difference in the different demographics as it goes through. But it is, SPSN, hospital, long-term care homes, any setting in the province where that PCR testing is done, that's all going into that percent positivity figure.
Can you describe SPSN
Oh,
Daniel?
sorry. The Central Physician Surveillance Network. So this is for, I should have said that. It's for physicians who basically sign on. This is a surveillance program where you would be doing still in your offices PCR testing for all of our respiratory viruses. So it's the combination test that does flu, COVID, RSV, all the above. And that's really what gives us the signal around the province of what we're seeing currently, what's the current spread in offices, and really not before we're getting to the hospital sites.
So having SPSN helps us overcome some of the biases, as the question infers. There is a bias to the current sampling frame, given its acute care, hospitalized, long-term care physician patient or patients. So being a member of the Sentinel Practitioner Surveillance Network is brilliant. We absolutely encourage you, given all of you are keeners and early adopters, to consider participating in that network, because that really will give us a better population-based approach to surveillance and understanding at a community level who's getting infected.
All right. Thanks to you both for that. The next question here pertains to COVID-19 rapid tests. So, based on the testing and treatment information document that's there, it indicates that COVID-19 rapid tests can be used in emergency rooms in a hospital. However, this participant says that their hospital has said that rapid tests are not allowed to be used, and this then can cause a delay in care because they're waiting for the PCR results for COVID. Is this something that could be clarified in terms of being able to use these in hospitals and emergency departments?
Yeah, I can't speak to any individual hospital specific policy, of course, but these are intended to be used broadly in all of your offices, in emergency departments, urgent care, walk-in clinics, long-term care homes. It's available for COVID because it gets us a little bit faster if positive. Obviously, in a lot of these settings, you'd still want to confirm with the PCR if it's negative. It's not perfect. It does miss a fair proportion, but we are confident in a positive result with these rapid tests. And so for the portions that do come up positive, we can be happy that it is a positive result. But it should be broadly used, and we do encourage use of them at this point in the season to see what we can get, ensuring that it's available so we can get that rapid identification. Again, I can't speak to an individual hospital policy, but happy to follow up if there's questions.
And one question the physician could ask is turnaround time. If your PCR turnaround time isn't going to meet the clinical window for treatment, I would absolutely question why we don't have point of care testing available. And as Daniel said, a true positive, a positive is a true positive. The negative, we still would question. And my goodness, clinically right now, influenza is the highest probability of anyone with an undifferentiated fever, cough, respiratory illness. So pre-test probability, knowing where we're at with influenza right now, can also help.
Okay, thank you so much. Actually, you helped answer the next question, because there was a question about, if we're seeing a lot of kids, for example, getting really sick with high fevers for 5 to 6 days and cough, no swabs available. Let's say we can't do some sort of PCR test. Is this likely flu or RSV? So it sounds like it's most likely going to be flu.
At this point, absolutely, flu would be the most prevalent as per the PHO respiratory virus tool, and depending on where you're at in the province, and it would be the highest prevalent organism. So we'll continue to monitor. RSV percent positivity is exceptionally low right now, and as soon as it gets over 5, we'll see it probably take off more rapidly.
I see. Okay, thanks so much. Another question here about HEPA filters. So HEPA filters are supposedly supposed to reduce the viral spread. Can you please review the evidence for this, and should they be encouraged in daycares and classrooms?
I can start to jump in, Dr. Moore. This is obviously something that we had a lot of discussion about during the pandemic in terms of filtration, air conditioning systems, HVAC systems, how they work. So it's probably not as simple to say as yes, a HEPA filter will improve things. You may be in a building that already has excellent air filtration systems, and that HEPA filter may not add significantly depending on it. So it's to just say yes, definitely use it is probably something that I shouldn't say. Like, it does require a bit of an assessment of the space, and there may already be a MERV 13 filtration system on the existing HVAC, and that HEPA filter won't add a lot. If it's an older building, if it's not an up-to-date HVAC system, if it's a small room that doesn't have windows that you can open, that sort of stuff, then we do see a benefit from that HEPA filter, not just for virus, but dust and other allergens that can help reduce, but certainly can help with viral spread as well. Will that make the difference in a daycare setting where we have, lots of young children touching each other and putting things in their mouths all the time? Probably not, realistically. Like my 3-year-old, she's still going to catch whatever she gets at daycare because they're touching everything all the time. But will it make a difference in terms of some of the respiratory spread in other settings where that isn't there? Absolutely, we still see it. But again, depending on what that filtration is already in the existing system.
Perfect. Thank you so much for that. That's helpful in terms of that nuance there. So another question here, just going back to COVID vaccination, are we still suggesting it then for low risk individuals who don't really have any underlying medical conditions and are young?
You want to take it away, Daniel?
Sure, sure.
It is a risk-based approach, but I'll give it back to Daniel.
Yeah, I mean, similar to flu, it's still recommended for everybody. Certainly, we know that the benefit of is obviously more significant for people who are, for COVID, older adults who have comorbidities. For flu, it even includes infants and kids under 5, where we see those higher risk outcomes. For a healthy person in the 18 to 50 range, they're unlikely to go to hospital if they get flu or COVID, either one. Do you still get benefit from reduction in the chance that you're going to get sick in the first place? Absolutely. If you are less likely to catch it, are you less likely to transmit it to others? You certainly still are. But it becomes much more of a risk-benefit discussion to get to those younger, healthier age groups where the main goal of immunization is really to prevent severe outcomes and hospitalization. For any healthcare worker, I would still recommend for sure. There's a lot of exposure you're going to get in the healthcare setting. You don't want to transmit to patients, all that sort of stuff. For someone else, it may not make as much sense just depending on their work and their different exposures. And that's reflected in the nasty language where we have still the very strongly recommended groups, and then other groups where it's, may receive it this time and this is the benefit, but, probably worth a bit more of discussion. Other things you'd add to that, Kieran, or?
No, just to address one of the comments. So our COVID vaccination strategy now is the fall and the spring. We don't want to have a lot of wastage in Ontario. This is still an expensive vaccine, so we maintain the supply for when we anticipate the peak being. So off season, it will be much less available or not available because of the cost and limited uptake that we've seen. So if someone's taking it for travel purposes going elsewhere, it may not be accessible and available. That's because we're limiting it to the highest peak periods for Ontarians when we're anticipating a rise in activity of COVID.
Okay, thank you. Thanks for responding to that. That was a comment that was in the Q&A there. So thank you for addressing that too. So then I'll move on to the next question here, which is that someone's expressing that their biggest challenge is patients hearing how the flu vaccine is ineffective this year. And they're even hearing that sometimes where leading health professionals are saying that and will not therefore accept the vaccine. And even sometimes elderly patients will refuse to take the vaccine. So it sounds like some of this language might even be coming from health professionals themselves. So just wondering if you guys can clarify that from a public health standpoint around the effectiveness and the importance of the flu vaccine.
So it is a nuanced conversation. Influenza in Ontario at present is H1N1, H3N2, and we anticipate influenza B in the spring, which is its traditional timing. And the vaccine protects you against all three. It is the H3N2 component, the subclade K of it, that has moved away from the virus in the vaccine or the antigen in the vaccine. So it's a nuanced conversation. We are monitoring the vaccine effectiveness around the world. In England, they've had good effectiveness, especially in children, although they use a different vaccine. And in the elderly, it's still 30 to 40% protection against the subclade H3N2. And we have high dose or adjuvanted vaccine for our over 65s as well as high risk. So we anticipate it'll still give protection. It will be less than the traditional 50%. And it's still important to acknowledge that it is our best tool to prevent admission to hospital, to significant morbidity, mortality at a community level. Daniel, anything? I know it's a complex discussion, but anything else to add?
No, I think you covered. The key is that it's still going to be a benefit. We don't know exactly how much, but it still will benefit. I think that's the main point.
Hmm. Yeah, definitely. So hopefully that helps, and hopefully we can all try and correct those misconceptions as well too around it, because it is still a very important thing to do. So thanks so much for that. Another question here around masking again. So Ontario recommends wearing a tight-fitting, well-constructed mask in indoor public settings. However, sometimes hospital staff are wearing more loose-fitting medical masks, if any masking at all. Is this because of cost, or is it because of a lack of knowledge or enforcement? Like, what's going on here?
I can speak to the supply of masks, which is that we have a very robust supply of masks from like ASTM level 1 through level 3, N95s, like more significant masks. Like that is readily available through Supply Ontario, as Dr. Moore mentioned, and that's supply for all of our hospital sector partners, and to all of you if you want to order them in your offices through the Supply Ontario portal. There's no concern in terms of the supply of masks. I can't speak to, individuals and how well they wear them. That obviously remains an issue and continues to be one, but we still strongly recommend the tighter fitting mask, particularly in patient-facing areas. If you're in the back hallway somewhere away from everybody, may be reasonable to be a little bit more lax in how you're wearing that mask, but in a patient-facing area, seeing patients in particular, or, in front of with other healthcare providers where you're providing care, that's where it's most important, and the supply should not be a concern.
Okay. Thanks so much. And maybe the last thing I'll ask, because I see a couple questions regarding it further down, and just given that it was brought up a little bit, is around the avian influenza. And is there right now any community transmission? And I know, Dr. Moore, you had mentioned a bit about the pre-pandemic vaccination. Is there any update in terms of healthcare workers having access to that? I just saw there were a couple questions on that theme, and that'll probably close us off for the
Yes.
Q&A.
So we've had no community transmission, no Ontarians. And whenever you test positive for influenza and it's a non-typable sample, we don't know if it's H1, H3, or influenza B, it is sent off to see if it's an unusual strain like an H5N1. So we have a very good laboratory-based surveillance. We've not had any humans in Ontario or Ontario test positive for H5N1. And the vaccine is a risk-based vaccine for frontline workers who are at that animal-human interface, mainly, obviously, birds and veterinarians who are having to clean up facilities that have had an H5N1 infection. And so it's not necessary from a physician vantage point, but we do have ample supply if we see that we have transmission amongst humans. But there has been none. So I will keep you appraised, absolutely, most likely through this venue if we see any risk. And I'm just sorry, I saw a question from Mary Sullivan. No resistance that we're seeing in any of the influenza strains to Tamiflu, so also Tamivir. And we monitor for the the amino acid change in the virus that indicates that resistance is a possibility, and we're not seeing any of it at present, but we'll absolutely keep you informed through this avenue and others if we see any change in resistance patterns.
All right. And just because this was a super critical question, I'm going to ask one more, which is just around the Tamiflu recommendations, the oseltamivir that you were mentioning before. So based on that guidance, if someone comes into our office and they just have a really bad cold, we're not able to test for that to determine whether it's rhinovirus versus influenza. So are we supposed to prescribe oseltamivir to pretty much anyone coming in with a really bad cold?
So again, primarily this is for higher risk individuals who are likely to go to hospital. Again, I wouldn't prescribe it to a healthy person coming with a cold. Hopefully they're not coming into just with a cold in the first place if it's a healthy younger person. If it's an older adult, if they have underlying medical conditions, as Dr. Moore mentioned, and at this time of year, depending where you're in the province, flu is the most likely thing in that differential. Take a look at the Public Health Ontario website. You can look a little bit by health unit in terms of what's more prominent right now, but it's most likely to be flu if they're coming in, particularly if they're, if it's an infant or child coming in. Like I said, that's almost 30 to 40% positive for flu right now. So that's where you want to think about it. Obviously, have a discussion with the patient on the risks and benefits from it. Tamiflu is a very well tolerated medication overall, so the risks are fairly small from it, but you still obviously want to make sure. But this is the time of year where flu being most likely, and we're likely, as we mentioned, to peak in the next maybe 2 to 4 weeks. Almost everything we'll see at that point is most likely to be flu. So that's what you can do. Again, it's still something, if they go to the hospital, they can get tested, and then some antiviral medication can be stopped if it's someone who's looking really severe, and still send them to hospital if you're concerned. But if you think it's looking like it might be more severe respiratory illness in somebody, they are higher risk. It's the time of the year where flu is predominant. That's where we would consider it. And the OH guidance goes into, even significantly more detail than I just said about how to make that decision.
Amazing. Thank you so much. All right, now for real, we'll close off the Q&A. Thank you both so much for that. There are a ton of questions still in the Q&A, so if you'd like, you can answer them too via writing messages to the people asking them. Thank you so much again, and thanks again for all that you've done for this community of practice. So, today, as we celebrate 100 sessions, we also want to recognize over 130 unique and incredible speakers who have shared their knowledge and experience, and the more than 60,000 participants who have joined us to learn, connect, and lead. And so, if we can go over to the next slide, please, we actually have a short video that we'd like to play. Thank you so much for that amazing video. What an achievement. And reaching 100 sessions is more than just a milestone. It is a celebration of family physicians leading effective change. It honors the progress that we've all made and reaffirms our commitment to keep learning, innovating, and shaping the future of healthcare. These sessions have given us practical tools and peer support, with 97% of participants reporting a positive experience and 95% finding the content relevant and actionable for their practice. Through changing the way we work, we've rethought how we care for patients, how we support one another, and ultimately, we have changed the way that we work. And in doing so, we've strengthened family physician leadership across the health system. I'm going to call Eleanor back to help me out with this next part. Over to you.
Thanks, Ali. So I just wanted to comment. We always flip through the slide that thanks our scientific planning committee because we're always keen to get to our content. But I wanted to do a shout out and say thank you to them, some of them specifically in just a moment, but also to Dr. Harry O'Halloran, who's one of our family physicians on the committee. He also wears many other hats aside from working in Collingwood. So a thank you to him. And there he is. Thanks, Harry, for all your hard work over many years now. And then none of this would have been possible without our teams. So we have teams within the Department of Family and Community Medicine and also within the Ontario College of Family Physicians. And honestly, those are the folks that make sure that these sessions run smoothly from one session to the next. Individually, they've brought their expertise, their collaborative spirit, and their commitment to improving and promoting primary care. And together they've helped bring this community of practice to life. So I wanted a big thank you to Julia, Pavithra, Marissa, Aaron, Jay, and Angeline. They work tirelessly behind the scenes to make sure that things work. So thank you for all your hard work. And with that, I think I'm turning to the next slide, which is to say a big thanks to Dan. Dan, we believe you might be the person who's been the most frequent speaker at more than 35 presentations, and I'm not even sure that 35 includes the times where you were just behind the scenes answering questions for us. We have a photo of you from your first session, I believe, or close to your second session, February 5th, 2021. So thank you for that. Another big thank you would go to Dr. Alison McGeer, who wasn't able to join us, but also was really pivotal in providing ID expertise in those early years and in the last few years as well. So thank you, Dan. We really appreciate your work and hope to have you continue. And at some point, Dan is going to do an MSK presentation because he actually does wear another hat in sports medicine. I know you guys probably none of you knew that, but yes, he doesn't just do this stuff. And I think then back to you, Ali.
All right, sounds good. I'm not sure, Dan, if you wanted to say something. I saw you come off mute. If you want to, please go ahead.
Oh, I was just gonna say I have aged significantly since that photo was taken, so thank you for the reminder.
All right, over to the next slide. All right, so I think this is actually Jobin. Over to you, please.
Thanks so much. And again, huge thanks to our planning committee, to both of our moderators, Ali and Eleanor. You have really made this look seamless. On behalf of everybody, I'm sure you've seen the chats. Huge thanks to our teams as well as our speakers, and of course, Dan as well. So as we've had this amazing community practice, it's actually allowed us to continue to expand our abilities. We've recognized this is something, and we've seen in the chat that there's lots of interest to have this type of approach. So we are in the process of trying to think about some other ways of doing this, and we are trying to gain insights into how we can do this. So if you are an early careers family physician, we ask that you scan that QR code, and if you're a resident, scan the other, so that we can try and make sure that we can do a version of this for you. But we want to make this as useful as possible. As I said in the chat, this community practice has allowed us to iterate and make this as amazing as it has been. Next slide. Our practicing well continues to move forward, and we're having many different community practice, as you see here. We also have our health equity community practice as well. And don't forget about our Peer Connect mentorship, which also has main pro credits. Next slide. I'm happy that I'm going to be able to host the upcoming antimicrobial stewardship in primary care. Dr. Kevin Schwartz and Dr. Noah Ivers will be our speakers, and that's on January 16th from 12 to 1, and we welcome you to come as well. Next slide. And I hand this back to you, Ali.
Thank you very much. I just also wanted to highlight the Primary Focus podcast that's led by Dr. Tara Kieran, our founder of this community of practice. And Tara is doing some amazing work learning about leading practices so that we can better learn how we can design our own primary care system here in Canada. And so last season, she had focused on the Netherlands and some of the great innovative work that is going on over there. And more recently, she actually has done a recent podcast on this particular clinic in Calgary that is doing team-based care in a really innovative way and actually enhancing profoundly the amount of access that patients can have in terms of their access to primary care by leveraging a team-based model really effectively. The patient panels are now 30% larger than their peers. So a really cool episode there to consider, along with the many others that Tara has put together. So do check it out. It's a really great podcast. Next slide. Also, just wanted to highlight the DFCM First 5 Years community of practice. So if you are an early career physician, in addition to doing the survey, please do consider attending these ones. As disclosure, I actually am on the scientific planning committee for this one too. So it's a great series, and we focus on issues that are specifically relevant to the first 5, and they run in the evening time as well. So keep an eye out for the registration link, and we hope to see you there. Next slide. Again, as a reminder, and for those who are new, we do record these sessions and they are posted on the DFCM website. So you can check out the link over there, and a few of our more recent sessions are highlighted there, but all of them are on that website. So feel free to check them out. And remember, you can get credits for it if you watch it later. Next slide. So please save the date for the upcoming sessions, the next one being in the new year. This will be our last one of 2025. So I do want to take an opportunity to wish everyone a wonderful holiday season. And thank you so much for all that you do day in and day out working in primary care. I know there are lots of challenges, but you truly are heroes of our healthcare system. And you are saving lives every day. You are preventing serious illnesses. You're making sure people are getting vaccinated and doing all the really, really important things sessions that are so valued in our healthcare system and so important for all of our patients and our community. So thank you all so much for all that you've done. I wish you all an amazing, safe, and happy holiday season, and looking forward to seeing you again in the new year. And here's to 100 next sessions and to innovation, collaboration, and leadership that will continue to change the way that we work. And with that, we'll close. Thank you all so much and happy holidays, and we'll see you in 2026.